So I presented some data which was a subgroup from the first-in-human study of belantamab mafodotin for patients with relapsed and refractory multiple myeloma. The phase 1 first-in-human study has now been published and presented, and this is investigating an antibody drug conjugate that targets BCMA. The conjugate is MMAF, which is linked very tightly onto the antibody and induces cell death. What was published previously was an overall response rate of 60%, and the updated results demonstrate a median progression-free survival of 12 months. So the purpose of our abstract and presentation at IMW in Boston was really just to focus on some more patient-level detail in the management of the ocular events that happen with this compound. Essentially what we're showing is that with close liaison with ophthalmology colleagues, you can effectively manage your patients when they do develop corneal events. And by doing so, you can continue to dose your patient, and then our patients did very well with a very deep and durable response. So when you look at our cohort of 5 patients that were treated at the recommended dose, when we followed them up for 32 months, their median progression-free survival is 17 months. But interestingly, what we find is that when we cease treatment, patients remain in complete response. And we have patients who have been in complete response for over 20 months without treatment. And that's unusual at a 4th or 5th or even 6th line treatment, where patients are typically on continuous therapy. And that speaks a little bit about how potent this drug is. So given the effect of this agent, it's very important, therefore, that these corneal events are very well managed. And what we show in our poster is that when you treat patients with belantamab, then they do develop corneal symptoms, namely dry eye, photophobia, and blurring of vision. You need to work very closely with your ophthalmology colleagues here, and what we did was that we increased the frequency of dexamethasone eye drops right up to 2 hourly, giving artificial tears, prophylactic antibiotics into the eye until the symptoms get better. Once the symptoms get better, then you can restart the belamaf dosing, normally at a 25% dose reduction. And then you carry on treating them. If the eye events happen again, then you do the same process. You interrupt treatment, increase the frequency of eye drops, and then re-challenge. But the key here is very close and good liaison with ophthalmology colleagues, because giving high-frequency dexamethasone eye drops does have sequelae, namely infections and raised intraocular pressure. And you do need some specialist input to ensure that these don't happen, and if they do, then they're managed accordingly. And that's really what we did. And the other point to just talk about is that because this compound is so potent, we demonstrate that we were stopping treatment for almost 90 days in patients, and they maintained their response despite that. So again, just providing a bit of reassurance for clinicians that if you do see the eye toxicity, just hold on a little bit. The likelihood is that the response will be maintained until the eye is better, then you can carry on dosing your patient and get overall the best responses.
Yeah, I think what's really quite striking about the antibody drug conjugate targeting BCMA is its high overall response rate. In Dr. Trudell's study, it was almost 60% in all patients, about 40-ish, 35 to 40% in penta-refractory, if you will. So I think that really represents an exciting target for us, especially because there are no steroids in it, and that was raised during the session. We will likely see data, we will hopefully see data at ASH on a pivotal study that may lead to the FDA approval. And I think the advantage that the ADC has is that it's off the shelf, again, similar to what we see with a BiTE. And so it may be a proof of principle that targeting BCMA with something else down the road may work, because if you respond to the antibody drug conjugate, that may be a marker that you're BCMA target sensitive.